Welcome to today's episode of Talking Tinnitus. We're back here with Dr. Gail Whitelaw. Gail is the Director of Speech Language Hearing Clinic at The Ohio State University, and she's a past president of the American Academy of Audiology. Gail, you're very welcome back to the show. It's a pleasure to have you again.
Thank you, Neil.
So today we're talking about tinnitus and hearing loss. And I think hearing loss is, widely regarded as the number one cause of tinnitus. And certainly there's a big overlap between hearing loss and tinnitus. What's your perspective on that generally?
I think that historically, we think that tinnitus was caused by hearing loss.
Sure.
If you look at some of the older data, it talks about how do people get hearing loss, noise exposure, and we know that tinnitus goes along with that. However, in my practice, I probably see at least, 40, 50% of people who don't have a hearing loss on an audiogram.
Okay, so they test well.
They test well, yeah.
Yeah.
And sometimes they come from another practice. One of the things we like to do is we like to look at very high frequencies because sometimes that's not tested in the typical audiologic perspective, but it can give us some more information that we might not have if we don't take a look at that. I work with a lot of people who maybe have had some kind of a head injury, some kind of a motor vehicle accident, for example, and afterwards their main complaint is tinnitus. And they find it really annoying when they come in and we start to talk to them and we want to talk to them about their audiogram, the graph of their hearing, because oftentimes they'll say, "Did you not hear me? I want to talk about my tinnitus." So I think that's an important population that's often overlooked. And we'll see those patients that come to our practice and maybe they came from another audiologist or from a physician's practice, and they said, "You're fine, you have normal hearing."
Okay.
And so we can couple hearing with tinnitus, but we also have to think about uncoupling it for certain patients.
Because there may be other causes. And then I think for patients that, what about the patients who have both? So they have tinnitus, they have hearing loss, and to your point, they say, "Hang on, why are you talking to me about my audiogram? I'm here for my tinnitus." And so if you get somebody presenting in clinic with both, how's the clinical judgment or pathway on which one to treat? What kind of, things do you need to look at to make those decisions?
We spend a lot of time doing shared decision making with patients.
Okay.
It's the clinical style that we use for counseling.
Yeah.
So when a tinnitus patient comes in, I think one of the most important things we do is say to them, "Tell us why you're here today." And when they talk about this ringing in my ears is really so difficult, their hearing loss isn't their main focus. And many of the people that I see when they come in, especially with a high frequency hearing loss that you might see from noise exposure or age related hearing loss, they may not even acknowledge that they have a hearing loss. They might be surprised by that. So I usually let the patient guide what we choose to do. However, I like to talk about hearing aids because for a lot of patients, hearing aids kind of kill two birds with one stone. It looks at how do I help habituate your tinnitus? Many hearing aids nowadays have tinnitus programs.
Yeah.
And the other part of that that's important for somebody who might be looking for an audiologist who will fit them with hearing aids to try to get both tinnitus and hearing loss addressed is they should ask, do they use real ear verification? Because what all of the research says is that the best fit hearing aid for a patient with tinnitus has to be fit well. And it's not just I slap this on and say, "Hey, Neil, good luck to you. I hope those hearing aids work for you." If we are going to go a different direction with that, I tell patients that if you have a hearing loss, there's kind of a three-pronged approach that I like. One is sound treatment, and my preferred sound treatment is linear. One is hearing aids, and one is some kind of therapy, some kind of mental health support. So if somebody comes in and says, "Yeah, I just want to talk about my tinnitus," I want to spread the whole picture out for them so they know kind of what we're walking towards, what the path might look like. Now, if somebody comes in and says, "I have no interest in trying hearing aids ever, I want linear," and I've had people tell me that, we work with linear. I've had people say, "No one's explained to me why I might benefit from hearing aids, and I really want to explore that first before I explore linear." particularly if I'm going to have to wear hearing aids in the long run.
Yeah.
And I'm a great believer that most people with communication issues, whether it be tinnitus or balance disorders or hearing loss, are going to need some kind of mental health support.
Sure.
That we don't, as audiologists, we don't do the right job. I might provide some of that myself to a patient, but generally, I want to know what um, my expertise is and refer either to an online program like Mahana or Odo, or Dr. Jennifer Gans's program, which is incredible, or to someone in person. So I want to make sure that we cover all those bases and that they're making an informed decision about hearing loss versus tinnitus being supported by somebody who can do mental health with them.
That makes sense. That makes sense. So I suppose maybe the summary is that we acknowledge and have accepted, a close relationship between hearing loss and tinnitus, but we need to make at a certain point a conscious uncoupling and acknowledge when patients have a preference maybe for how they want their own care to
Absolutely.
as long as they have the right information.
Absolutely.
Sure. And would it be fair to say that from a practical clinical perspective, if a patient is bought into the decision because they're involved and are they more likely to be compliant as a result of that, do you think?
That's absolutely. I've absolutely found that um, sometimes patients will come with a spouse or a child, adult child, and they'll try to give input. And the person's like, I don't ever want to wear hearing aids. And I understand that. Hearing aids still have a stigma attached to them. And someone might be like, I don't want that stigma. I want to do something like linear where I can do it for an hour a day and see if I can get relief. And so when they buy into it, I absolutely agree with you. The outcomes are so much better.
Thank you very much. That's very insightful, Gail. I feel like I'm learning more every time we chat about clinical process. So appreciate you joining the show today and for your time.
Thank you, Neil.